A remarkable course with wonderful speakers, very clinically relevant. So it's really a pleasure to be here, and I think the organizers really do need to be congratulated for the effort put into developing this course. Well, this is a challenging topic because it's difficult to limit in a short time to all of what we've been able to achieve in structural heart disease over the last few decades. You have many experts that are here. I want to acknowledge some of them for sure. Sitting in the front, we have Eberhard Grube, we have Samir Kapadia, Sushil Kadali, Pradeep Yadav, Alex Abizad. We have some true pioneers in structural heart disease. So this meeting is blessed by having some real expertise. I'll share some of my impressions selectively, recognizing that it's impossible to comprehensively cover this area in the time allowed. These are my disclosures. And I'll divide this up with some initial foundational reflections and then divide it into what we've been calling the TAVR revolution, discuss mitral therapies, which I think are still a work in progress, and some of the promising newcomers in the tricuspid field. The first time we used the term structural heart disease was in an opening address at TCT in 2001 when we were talking about the dramatic explosion of new therapies in interventional cardiovascular medicine, most of which have come to fruition in the subsequent 2 decades. So this is the first time we talked about a new category of transcatheter therapies using this term of structural heart disease, which was truly meant to be a wastebasket term to include all non-vascular procedures utilizing catheter-based technologies, largely divided into the valve side and also the non-valve, adult congenital heart disease, left atrial appendage closure, heart failure interventional therapies, and other novel treatments. It emphasized the confluence of 2 fully evolved concepts, non-vascular image-guided therapy, at that time using essentially echo and MSCT, and also multidisciplinary heart team strategies with careful pre-procedure planning. This was unusual in interventional cardiology at the time. It also required significant adjustments in training of interventional operators and imagers, and modified treatment milieux like hybrid cath labs and ORs, and also different clinical care pathways. So this was a different group of procedures done in different patients, done in a different way. At the time, we needed a leader, and I must say, and I need to acknowledge Alain Crebier as truly being the first-in-man pioneer, having carried this revolution to the earliest balloon valvuloplasty in the 80s, and then a lot of myocardial procedures done with commissurotomy in the 90s, and then, of course, to TAVR, the first case in 2002. So Alain was our leader, our pioneer. He was a caring physician, a humble humanitarian, a creative iconoclast, and a gifted transcatheter operator. His 2 most endearing qualities, I believe, were passion and perseverance, which led him to succeed in realizing this crazy dream to transplant a heart valve in a beating heart in an awake patient. And he truly loved India. Used to come here monthly and do procedures in patients that were underprivileged and didn't have access to care. And he would end most of his lectures with this quote from André Gide: "One doesn't discover new lands without consenting to lose sight of the shore for a very long time." So unfortunately, Alain has left us recently, but his memory remains, and I think he's inspired a lot of his colleagues and followers to continue this field. So I'm going to talk largely about transcatheter valve interventions. But I want to point out that they are in dramatically different developmental stages. There have been more than 2 million TAVR procedures performed up until this point. I would say TAVR is in a relatively mature, at the very least, young adult stage. There have been about 200,000 transcatheter mitral procedures, and I would argue that mitral disease is still in its adolescence. And then there's the newcomer, transcatheter tricuspid disease, with only about 20,000 cases having been performed. And certainly we're learning. We're still prepubescent. There's a lot about the disease we need to understand. So the future is a little bit more difficult to predict, but also exciting. Back to Ilan, after he did his first procedure, I spoke to him about 15 minutes later. We talked about what would be the next steps. And the first thing that he said was, what now? He really didn't have a sense that TAVR was going to go very much beyond the sickest patient that had no other alternatives. Certainly, no one could have predicted that we'd see a rapid evolution of technology, a lot of procedural refinement and simplification, an avalanche of clinical evidence, this concept of the heart team become embedded into clinical care, and a dramatic reduction in complications with improved clinical outcomes. As an example, just showing the partner trials here, over 10,000 patients randomized in 5 studies that resulted in more than 200 manuscripts, 11 of which were published in the New England Journal of Medicine and Lancet, as an example of the evidence-based medicine that was brought to bear to legitimize this particular area. This resulted in explosive growth in TAVR. This is the STS registry, where you can see that yellow line passing surgery for aortic stenosis. And by 2018 being the most common procedure done in the United States to replace the aortic valve, with over 100,000 procedures, and in 2024 estimated about 120,000 done in the United States. And this began this global structural heart revolution, where about 500,000 procedures will be performed globally by 2026. I think the innovation of TAVR was mainly simplification. It wasn't complexity, it was making things simpler. We had something that looked like a stent, that was balloon expandable, that was easy to implant, and behaved like a surgical bioprosthesis. I also think that it really evolved into these 3 foundational pillars, that we would use a heart team that was multidisciplinary to be able to diagnose what was wrong and to make decisions about therapy, that we would guide that therapy using imaging that was not typically used in that mode previously. And most importantly, at least to me, and as it speaks to the future, is that we would not just consider the index procedure, but we would think more critically as physicians, not just proceduralists, about what happened before and after that procedure. So we now think of aortic stenosis as being a lifelong disease, but we focused on the index procedure initially, as perhaps we should have, but now we're focusing, and in the future I think we'll become obsessed with what we call the upstream and the downstream effects. Upstream, how do we improve diagnosis? How do we improve access to care? Should we be treating these patients preemptively in a pre-symptomatic state? And can we delay calcified aortic valve disease pharmacologically? And downstream, how do we improve bioprosthetic valve durability? How do we deal with things like therapy sequencing and concomitant cardiovascular disease? And should we also be using adjunctive pharmacotherapy to manage associated syndromes in aortic stenosis, particularly for what we call non-responders? So I'll refer to this manuscript that was first authored by Philippe Généreux, who was one of our fellows at Columbia and has now become truly a leader in the field, developing a staging classification for aortic stenosis that went beyond hemodynamic valve severity to look at cardiac damage. And looking at a large number of patients as part of the partner trials, you can see that using this staging classification, that more than 85% had greater than stage 2 cardiac damage using this echo staging system before we did AVR, 85%. And if we looked at 1-year mortality after successful AVR, it tracked perfectly relative to the initial cardiac stage before treatment. And as we go beyond and look at the changes in cardiac staging after successful AVR, you can see that with a baseline cardiac damage stage of 2 or greater, despite AVR, more than half of the patients had no change or worsening at a year. And in fact, whether it improved, there was no change or worsening, predicted the 2-year death or heart failure hospitalization recurrence in these patients. So the hypothesis became, In severe AS, waiting for symptoms, and this is the classic trigger for treatment, for AVR results in more cardiac damage, which is not reversible in most patients after AVR, and predicts long-term adverse clinical outcomes. So this became the conceptual framework that we think is affecting our future management of this disease. That yes, AS is a chronic disease, but it's punctuated by various clinical events. The earlier management, coupled with meticulous follow-up, not casual follow-up, leads to optimal treatment. We think that delaying progression of calcific AS is still achievable, but it's an aspirational goal, and that clinical research efforts should shift from late-stage reactive AVR to early-stage preemptive AVR and other complementary therapies. And it's been the availability of a less invasive, low-risk transcatheter technology, we hope in the future, combined with more durable heart valves, that will, coupled with enhanced and early diagnosis, that in the future will transform AS patient management. So when are these preemptive studies going to actually come to fruition, and when are we actually going to see some meaningful data? I'm not going to go back to some of the smaller surgical trials that have been done in severe asymptomatic aortic stenosis, but I will tell you, you'll see in TCT in about 3 months the presentation of the early TAVR trial. Now this is almost 1,000 patients with stress test confirmed asymptomatic severe calcific aortic stenosis randomized to early treatment, preemptive treatment, versus what is clinical surveillance. A lot of other frills to this study, but this is going to give us the first indication of whether or not we really should be not talking about a hypothesis, but do we truly have randomized data that will indicate that early treatment makes a difference? We'll also see at TCT, coming up in 3 months, the EVOLVE trial, which is also a study in severe asymptomatic aortic stenosis using biomarkers and using gadolinium, cardiac MR with gadolinium scanning to assess whether or not there's enhancement that would predict an at-risk group. So we'll have another interesting randomized trial presented at TCT. And you'll also see for the first time a group of patients with moderate aortic stenosis, but have reduced ejection fraction, heart failure hospitalizations, in an investigator-initiated study called TAVR Unload. And I want to credit Nick Van Meegen for being really the energetic principal investigator in this study, to see if preemptive treatment is better than optimal heart failure therapy in these more complex moderate AS patients. So we're going to see a lot of new data, and I think it's going to frame the way we think about this hypothesis of preemptive treatment. So when we look at aortic stenosis and talk about how we manage patients, we generally focus on that vertical column of hemodynamic severity of valve lesions, as opposed to the horizontal staging of cardiac damage. And right now, all that's indicated are the green boxes. When we begin to see these new randomized data, we'll at least have some evidence or understanding how to best treat some of these other patient cohorts that have aortic stenosis. Now, we talked about upstream. Well, what's more upstream than getting an early diagnosis of this disease? It's very difficult to screen for aortic stenosis systematically. So a lot of work has been done now with artificial intelligence and machine learning. We have a group of 17 bioinformatics people at Columbia who are doing this work. And I want to credit Pierre Elias and Tim Potarucha and many others who've been working on this for the past 5 years and published recently their deep learning ECG analysis to detect left-sided valvular heart disease. Again, we don't have time to go over this in detail, but using 12-lead ECGs and artificial intelligence, there are 60,000 pieces of information from a single 12-lead ECG that are analyzed with pretty high sensitivity and specificity. You can begin to risk profile for left-sided heart valve disease. So we looked at 12 million ECGs, 1.5 million echocardiograms from 8 of the New York Presbyterian hospitals. The data was sanitized, tokenized, validated, and harmonized. And we developed a prediction score for structural heart disease with very high sensitivity and specificity. And this is now being applied to a randomized trial called the Cactus study, where every patient that comes into our emergency department, their ECG is analyzed for structural heart disease. And if there's a high prediction score, then patients receive an echo either as an outpatient or inpatient setting using a variety of different maneuvers. And we'll be able to see if by these kinds of early detection means, using things like artificial intelligence with readily achievable diagnostics like an ECG, that we can identify the disease earlier and then make decisions about whether or not management in particular ways are going to make a difference in long-term outcomes. So I've been focusing on upstream in aortic stenosis. Is there anything on the index procedure? Well, the indications are changing. Dedicated AR TAVR systems are being developed. One has been tested in an FDA study, which likely will have FDA approval in the next several months. It's called a Trilogy valve from a company called Genevalve. And these were patients that had high surgical risk, severe aortic regurgitation, with the primary efficacy endpoint of mortality at a year showing only a 7.8% mortality in these patients, markedly better than the historical comparators, and this was published recently in The Lancet. So yes, indications are expanding for TAVR into the aortic regurgitation space, and this will be one of the futuristic things we look at over the next 5 years. What about downstream? Well, certainly valve durability is really key, and let me focus on that for a moment. And why is that important? Because when we look at data like this, which is the TAVR and SAVR procedures done by age group in the United States, what we see is that in people under the age of 65 who get aortic valve replacement, right now in the US, about 50% are getting TAVR and 50% SAVR. We don't have any data in younger patients with TAVR, and this means that these patients are likely going to outlive the duration of durability of their bioprosthetic valves. So we spent a lot of time working on how to define bioprosthesis durability. This is the VARC3 document. I have to credit people like Philippe Pibero, Rebecca Hahn for doing this kind of work with a very complex algorithm for how we define bioprosthetic valve dysfunction and durability, which we're not going to discuss. But we now understand, at least, how to characterize the syndrome of structural valve deterioration. From the standpoint of TAVR, you can see what some of these surgical explants look like, and they look like failed surgical valves. So in the future, if we're really going to talk about treating younger people and preemptive therapy, we have to address the issue of durability. Right now, the major durability issue that we see is with surgical valves. And if we look at the TVT registry, most of the procedures being done are in failed surgical valves, very few in failed TAVR valves, which represent the blue boxes. But that is rapidly changing. We are at the inflection point now, and we expect that by 2018 that the number of failed TAVR valves will exceed the number of surgical valves, and you can see what's predicted over the next 10 years. So this is going to become a big issue that we're going to have to deal with in the future. So getting back to durability, to me, it's all about leaflets and material science innovation. There are many things that are being developed, and I'll just mention a few. We have a symposium coming a little bit later to discuss one of these. One is the Edwards Resilia tissue. Now this is interesting because it aldehyde blocks some of the vulnerable areas that promote calcification. It uses a glycerolization as opposed to other forms of storage that allows you to have a stable dry storage technique. It's now been incorporated in multiple of the systems. We don't know to what extent this is going to affect durability. There's some early surgical data that's somewhat suggestive, but we'll have to see. But there is new material that is now being brought to bear. Another example is the Dura AVR system, which is a single-piece, native-shaped biomimetic design that has some very interesting properties that allows for better hemodynamic performance and may promote greater durability. These are the data from an early feasibility study. Some of the people in this room have used this valve in some of these early feasibility studies, showing dramatically improved hemodynamics for an intra-annular balloon expandable TAVR system. And finally, there's the TRIA polymer valve, the only true polymer valve with the largest cohort of patients being treated in India. And this is a blend of polyurethane and siloxane, and this is the surgical valve. These are two transcatheter valves that are being and have been developed, so we can look to this in the future, again, as another area of interest. What's, to me, most provocative about this system is the entire manufacturing is all done robotically. Very precise, very reproducible. There's no human handling of this. It's not labor intensive. There's no sewing. And these small, efficient robot pods can be placed anywhere. So these kinds of futuristic changes, if this turns out to be an important new valve material, certainly are going to make a difference to allow us to think about one valve for life. And finally, I think medical therapy is going to come back in treating aortic stenosis, mainly targeting the ventricle to protect a pressure-overloaded heart as AS progresses and to augment LV recovery after AVR. Might be some common medications. There are some interesting new studies with SGLT2 inhibitors, or there may be some new medications, but this is going to come back. And a lot of exotic clinical trial pathways being used where we use things like adaptive randomization and real-time Bayesian analysis and common control groups to be able to facilitate and accelerate the clinical trial process using different imaging endpoints. So we want to fill even that other box of earlier stage disease with a multi-drug precision medical therapy approach. So this is truly where the future of aortic valve therapy is going. We expect that TAVR will be the dominant technology for AVR in the future and the default therapy for most AS, and I'll predict even AR anatomic scenarios. There are still evidence gaps we have to address, especially in younger patients, and whether or not this preemptive concept makes sense. We do think the conversation will shift to bioprosthetic valve durability and preferred therapy sequencing with earlier upstream treatment, and also this concept of trying to manage TAVR non-responders. So innovation will also focus on AI and machine learning for screening and device phenotyping and novel, more durable valve leaflet technologies. So that's where aortic valve disease is going. Very mature, very well defined, and I think continuing to progress with a lot of innovation in the future. Mitral therapies, I think, are still a work in progress. The anatomy is complex. The device landscape is overwhelming. It's a complex disease with many overlapping solutions. If we look at mitral valve transcatheter clinical trials compared to TAVR, they are two trains with two very different speeds. The black rectangles representing TAVR studies, the red representing mitral studies. And it's because there are multiple anatomic targets and they respond differently to transcatheter therapies. The control therapies have been unstable, including guideline-directed medical therapy, and TEER has evolved. The complexity of transcatheter mitral valve therapies has been daunting. There have been frequent screen failures, challenging and fragmented clinical trial pathways. Mitral disease has been a challenge. And I want to give you an example. The hallmark study in this space in functional MR, I think you would agree, is the COAP trial. 5 years after the COAP trial, mitral TEER, in the treatment arm, the successful treatment arm, 73% of the patients were either dead or had heart failure hospitalizations, and more than half had died. So this is not a successful long-term therapy. And this was published in the New England Journal of Medicine. So we have to find ways to do better in functional MR. So we've just started an investigator-initiated study supported by Abbott called CardioClip. We're looking at these functional MR patients treated with MitraClip that are going to get cardiomems and are going to be monitored intensively to see if we can abort the later heart failure progression that causes all of those clinical events that we've been talking about. It's a small study. It's randomized 60 patients. And we'll see if this helps us to combine what would be a sensing device for heart failure with a therapy for mitral valve disease to deal with an overwhelming non-responder population in secondary MR. What about primary MR? Well, primary MR really has been largely a surgical disease. We do MitraClip, but it's supposed to be for those patients that are really not good surgical candidates. But there are some new trials, and one I'm going to point to is an NIH study called the Primary Trial. This is an all-comer study in primary MR in people over 60 years old. It's a superiority trial, and it's going to compare excellent mitral TEER in the best centers versus surgical repair. And we'll have some very interesting evidence that will help us to understand if we can take transcatheter mitral therapy using edge-to-edge repair to a much higher level in the future from the standpoint of being able to offer this to our patients with results short-term and long-term that would be equivalent to good surgical mitral repair therapy. Right now we have 60 sites, 5 countries. We'll complete enrollment by 2026. We're almost half enrolled, so things are moving quickly. But these kinds of progressive studies, I think, will help us in the future to decide where we're going to be going. Mitral valve disease is messy, and it's most messy when we talk about the TMVR, the replacement side of things. These are the first 10 replacement devices that were developed and used in patients for a variety of both primary and secondary MR. 7 of these no longer exist. We hit a dead end due to incorrect clinical assumptions, technology roadblocks, inability to enroll in clinical trials. A lot of it had to do with issues relating to what we call screen failures. And there were a lot of reasons. More than 50% of the time, it was LVOT obstruction potential or annulus size or small LV size, many different reasons. So screen failures became a big issue in this TMVR world. I won't get into the specifics. And right now the screen failure rates are 65 to 85% in ongoing US clinical TMVR trials. Part of it is also because mitral TEER is getting better. And the most recent results from the EXPAND G4 registry clearly indicate that you can treat more complex disease with a better outcome from the standpoint of residual MR. Therefore, the need for TMVR, a little bit unclear in expanding populations. But there are now second-generation TMVR devices, and I've now listed 8 of them that we think do have a potential to add something, particularly in the space of functional MR. And I'll just simply show you some of them. This is the Intrepid 29 French transfemoral system, which dramatically has increased the enrollment in the Apollo trial. It's a transeptal, smaller profile system that we think, again, will offer some advantages going forward. This is 3 different ways to manage that issue of LVOT obstruction. An open frame design with the HiLife device, a supraannular design, completely radically different, the AltaValve 4C device, and something called InnoValve, which really twists and spares the LV outflow tract by capturing the anterior leaflet of the mitral valve. Some of these new exciting technologies, the Sophia system, which is an over-the-wire system that's easily imaged, doesn't require pacing, very Mac-friendly, another target we think for these new TMVR devices. As I mentioned, this InnoValve device, which has 6 arms, and those arms attached to the frame, as you rotate the device, tend to capture the chordal apparatus and the subannular apparatus, and it brings the annulus and the papillary muscles closer together. It tilts the device posteriorly and restores bidirectional flow, and in the early EFS study has some striking echo findings suggesting positive remodeling for the first time. And the very radically different AltaValve, which is really an atrial implant with a valve sitting in the atrium. It's a series of valves entering a final phase now of a clinical FDA study. Many FDA studies that have been begun, none that are close to being finished. Just an example of one, the Apollo trial that's been enrolling now for 8 years and still not close to being done. So how do we define the path forward for TMVR? Well, we have to redefine the target population and anatomic requirements, develop these low-profile transseptal systems that are adaptable to anatomic variability, be able to address some of the real-world anatomic challenges like MAC, and develop flexible global clinical trial designs and networks with increased collaboration. So I don't think the future of transcatheter mitral therapies will be exactly the same as what we're seeing with aortics. I think it'll be more of a toolbox approach. I think surgical repair for primary MR and improving GDMT for secondary MR will still be important. I think there'll be significant TEER growth in the future and expanded clinical indications. And TMVR has transitioned to these low-profile TS access systems and should play an increasing role in secondary MR and MAC cases. So the vision is a little bit different on the mitral side. And quickly to conclude, what about this promising newcomer group of tricuspid therapies? For 2 generations, we thought about TR as an innocent bystander. Well, it's not an innocent bystander anymore. We know that severe and moderate TR has an impact on mortality in almost every setting. In this largest meta-analysis of 70 studies, it was clear that mortality was associated with a significant TR, independent of pulmonary pressures and right heart failure. So it's not an innocent bystander. We're still learning about this disease. We have new classification schemes of atrial functional TR, ventricular functional TR, device-related TR, and primary TR. We didn't even know how to grade the severity of TR until our colleagues, including Becky Hahn, came up with a system that helped us to organize this structurally to severe, massive, and torrential to really express some of the end-stage changes we're seeing because patients are underdiagnosed and they're undertreated, and this results in very late presentation and the need for an extended grading scheme. These are all the evolving devices that have been developed now at the annuloplasty level, at the leaflet level, and at the valve replacement, either heterotopic or orthotopic level. How to choose these has not been resolved yet. I will say that the FDA has approved 2 devices, the Evoke replacement system and the edge-to-edge repair TriClip system just recently. So we're going to get a lot of experience suddenly in the United States. I'll mention just very quickly some of the results of those trials. The TriLuminate study involving TriClip was a 1-to-1 study, a randomized trial versus medical therapy. The TriScend 2 was a 2-to-1 study that had some differences in the design, an initial cohort of patients, and then a later cohort adding up to 400 patients. This was also versus medical therapy. And the final data from this study will actually be presented at TCT by the combination of Becky Hahn and Sushil Kadali. Both of these devices are relatively safe. TriLuminate in particular demonstrated the TEER was very safe in the tricuspid position. A little bit less so from a safety standpoint with replacement using Evoke with a higher frequency of either bleeding or conduction abnormalities. So with higher adverse event rates, you would think this has to be balanced by increased clinical benefit. TriLuminate showed a reduction in TR, but frankly not as robust as we had expected or had intended, with about 50% of patients still having moderate or worse TR. When we look at the primary endpoint, there was no difference in death or tricuspid valve surgery or heart failure hospitalizations. The main clinical benefit was an improvement in patient-reported outcomes, yes, in a randomized trial, but not sham-controlled, and there could be a placebo effect that influences this. When we look at TriScend, certainly replacement, much more robust, essentially elimination of tricuspid regurgitation. 95% of the patients have less than moderate residual TR. And again, as we begin to look at the various endpoints, we didn't see very much of, we initially see a dramatic change in the patient-reported outcomes as shown here. But as we look a little bit further to an expanded cohort that was presented to the FDA, we still don't see very much of a change in things like mortality and heart failure hospitalizations, mainly the results dominated by patient-reported outcomes. But again, we have more patients that need to be examined and more data to look at longer time points to be able to really analyze these completely. So we've shown that these devices reduce TR. The safety profiles are certainly acceptable. Neither therapy so far has had an impact on mortality and heart failure hospitalizations, short term, but we need longer follow-up. And both therapies clearly improve what are patient-reported outcomes. So much more to learn. So finally, we think there's going to be some impressive growth in tricuspid valve therapies, either as sole therapy or combined with mitral therapy, and even potentially upstream as it's done in surgery. There need to be technology refinements for all of these device categories: repair, replacement, and certainly annuloplasty. What's needed? We need to understand what the preferred device is for specific anatomies. What are the improved imaging techniques needed for diagnosis and therapy guidance, which has been an issue in tricuspid disease? Understanding some of the risk factors like RV dysfunction and the complications like bleeding and conduction abnormalities, improved clinical management strategies, and better heart team training. So with this facilitated approval in the US, I still think we need to focus on long-term follow-up, further reflection on hard clinical endpoints versus patient-reported outcomes, and looking towards the future, expanded clinical indications. So much to learn with tricuspid disease going forward, although I would predict that 5 or 10 years from now, this will be the dominant therapy for significant, clinically significant TR. So trends in future direction in structural heart disease, I've given you a snapshot and gone as quickly as I can, even with my kinetic New York City speaking style. And was very selective in what I've discussed. There's much more to learn. This is an exciting area. So please join us at TCT 2024, which will be in Washington, D.C., for the next chapter of transcatheter structural heart disease valve innovations. Thank you very much.